all of you. I welcome you all for the fourth academic activity of Epilepsy SIG. I'm sure all of you are enjoying the academic activity of Epilepsy SIG. Today about interesting case presentations on seizure mimics. And we have got three experts and moderator to conduct this session. I request our President Dr. Shafali Gulati to introduce the experts and moderators for today's session. Over to you, madam.
Yeah, thank you. Thank you so much, Mahesh. Thank you. Asmita, can I have the slides? So having seizure mimics, so everything that shakes is not epilepsy seizures, so that is something important. So this is, we had sent out a note and we got an overwhelming response. We wanted only 6 cases, but now we have so many. So we plan to have it for 5 minutes. Well, Ranjit will give us the housekeeping instructions. And we have Professor Satinder Reneja, who is former director, professor, and head of pediatric neurology in Lady Hardinge Medical College, and a very amazing professional and a wonderful human being. And thank you so much, ma'am, for joining. And welcome back to India after you're staying so many months in the US. And Professor Gagandeep Singh was supposed to join. He is basically he's heading the Education Council of ILE, and he was the president of Indian Academy of Neurology last year. Right now, he's conducting an ILA meeting, so he won't be able to join. He may join later on. And next, we would very grateful to have Dr. Tajul Arifin bin Tajuddin. I hope I'm pronouncing it okay. I hope, all right. Okay, no worries. Okay, thank you. It was the first time I took the full name. So anyway, everybody knows him. Everybody loves him from India and Delhi, the movement disorder expert who had 10 talks in July in this year. He's consultant pediatric neurologist and movement disorder specialist and fellow who's done fellowship in movement disorder from the US, from Rochester. And he's a resident consultant of KPJ Puteri Research Center and visiting consultant Sultan Ismail Hospital, Malaysia. And his area of interest are movement disorders, autoimmune encephalitis, and neurotransmitter disorders. Idea for requesting him was because most of these movements are somehow in domain of the movement disorder. So thought he would be the best person to help. And from the other side, we have Dr. Aneja, who has had 40 plus years of experience in pediatric neurology. So we have the best possible combo here. And our moderator is a very senior former professor and head of Department of Pediatrics and Neonatology, Chief of Pediatric Neurology from KJ Somaiya Medical College, Mumbai. And she's a dear friend and has lots of awards and acclaims. So I hand it over to you, Sujata. Before that, I think Ranjit will give very clear housekeeping instructions and will keep interjecting in between to keep the time on track. Yeah.
Yeah, so good evening, everybody. So we have 9 cases over the next 60 minutes or so. So we will be having...
So I'll be 55 minutes. Yeah.
So each case presentation will be 5 minutes at the max, and the discussion will be for 2 to 3 minutes each. So at the end of 5 minutes, I will I will say that time is up. So please try to stick to that time. Over to you, ma'am. Yeah.
Thank you so much, Dr. Shefali and Dr. Ranjit. And we begin with the neonate age group. Presenter is Dr. Krishna Priya Sundaresan, and the moderator is Dr. Kavita, and institute is Bharati Vidyapeeth, Pune. Dr. Krishna Priya, can we start? Dr. Krishna Priya Sudarsana.
Yes, ma'am, I'm sharing my screen.
Thank you, dear. Sorry, I got your name wrong initially.
Good evening, all. Thank you, Yasin, for this opportunity. This is about a child. All that defense is not seizure. This is about a female baby who was outborn by emergency LSES for fetal distress and oligohydramnios and IUGR at 38 weeks of gestation. The baby was shifted to Bharati NICU at 24 hours of life with persistent high-grade fever up to 105 degrees Fahrenheit, noted since birth. Severe stiffening episodes of all muscles, including the face, associated with crying. Mother was COVID positive, but the baby tested negative. Pedigree. This was a third-degree consanguineous marriage, and the first conception was an IUD with skeletal dysplasia in USG. This was the third child. On examination of the child had microcephaly, dysmorphic features like wide prominent forehead, phimosis, short bulbous wide base nose, long philtrum, pursed lips, microretrognathia, and low set ears. Please note the movement in the video as well as the dysmorphic features. The child had an abnormal cry, pursed lips and grimace, a short neck, short bowed long bones with the wrist and elbow contractures. Simian crease was there. The child did not have any encephalopathy. Cranial nerves and fundus was normal. Axial hypotonia and appendicular hypertonia was there. There was no weakness. Other system examination was normal except for a hypernasal voice. So we were wondering if these stiffening episodes were seizures, but those were slower and more prolonged than spasms. Are they exaggerated mororeflex as in early CP or hyperexpexia, but the glabellar tab was habituating? Are they tetanus spasms because of the grimace and the abnormal cry, but the mother was immunized and good cord care was received? Is it dystonia, but the face is more involved and skeletal dysplasias are usually associated with myotonia? When looking at literature for help, we came across this very nice article on approach to neonatal hypertonia. In this article, very detailed algorithms are given, one of which is this. With respect to this very obvious dysmorphism, hyperthermia, and skeletal changes, we thought a genetic cause for the neonatal hypertonia is more plausible, like a neonatal neuromyotonic condition. And further workup, CPK was 1500. Basic metabolic profile was normal with an ammonia of 45 and lactate of 4. X-ray was showing skeletal dysplasia. EEG showed only artifacts. MRI showed no changes of HI. And an EMG was done, but no typical myotonia was seen. Clinical exome was done, which showed a pathogenic variant of LIFR, loss of function mutation, which codes for neonatal Schwartz-Jampel syndrome type 2, also known as Tuve-Wiedemann syndrome. Coming back to the baby, course of the illness, the baby showed some response to carbamazepine. MG feeds had to be continued because the baby was having a lot of swallowing issues. By day 32 of life, the baby developed NEC and succumbed to E. coli sepsis. On reverse phenotyping, most of the features were matching, but neonatal myotonia was not seen in the EMG, which was puzzling. So we went back to the literature and showed case reports where it was mentioned that a continuous high frequency, high amplitude potentials on EMG is seen and not the myotonic discharges. These discharges do not wax or wane in amplitude and frequency, unlike the typical myotonic discharges. And we also wrote to Dr. Mordekar sir, and he also confirmed that myotonia is not seen in the neonatal severe Schwartz-Jampel syndrome.
Right.
And summarizing, neonatal myotonia
Can you
is
wind up in 2 seconds?
Yes. Neonatal myotonia is a diagnostic challenge and it can be approached in a systematic manner. Coming to the take-home messages, all stiffness in neonates aren't seizures. A fever might be non-infectious. Neonatal hypertonia within 24 hours of birth is unlikely to be due to hypoxic ischemic encephalopathy. A detailed history and examination of the infant and often of parents might provide important clues. Some conditions have treatment or genetic implications, and neonatal hypertonia is probably an underdiagnosed neonatal seizure mimic. These are my references. Thank you.
Thank you so much, Dr. Krishna Priya. Very nice case. It's open for discussion now. I will request
Kavita's comments. Sujata, Kavita's comment. Kavita is the
Kavita, you're the moderator. Your case. Dr. Kavita? Dr. Kavita Srivastava? I don't think she can hear me. So should we open?
So I think it's very nice case, and really it's reminded me of one case which I saw when we didn't have any of these genetic diagnosis. And this was a typical case of Schwartz-Jampel. Fortunately, we also saw the myotonia in that case, and it was typical blepharospasms and also some amount of trismus, and it was misdiagnosed as tetanus and admitted to a tetanus ward. So this is a very, I must say it's a rare case because it's a very rare case. You don't see it very frequently. So very nice, and it's very good to be presented in this forum where we have so many, pediatric neurologists, because it's not one of the usual cases that we see. Thank you, Kavita and Krishna Priya, for presenting. And I remember it very distinctly. We thought of so many things. Unfortunately, we just made a diagnosis on based of the clinical features and not the dysmorphism as well as blepharospasm was a very characteristic of this case. Thank you, Dr. Taj.
Yeah, it was a very interesting case. My first differential diagnosis would have been the hyperaclepsia syndrome, either GLRA1 or GLRAB or the other mutations. But sometimes there's one syndrome called that I've recently seen with the mutation of BRAT1 mutation, which presents with the neonatal rigidity. The only thing that's different in this case compared to that is this child has got, this baby has got this episodic muscle contractions or episodic spasm-like posturing. In BRAT1 and in hyperaclepsia, usually the reflexes are increased, whereas in what you call neonatal myotonia or the Schwartz-Jampel syndrome, the reflexes are classically reduced in addition of appendicular hypotonia or rather rigidity-like syndrome. That's what. Very interesting case, very interesting case.
Yes, thank you so much. Is Dr. Kavita there? Would you like to comment? Okay. Dr.
Sujata, 1 second. Kavita is 1 minute. Sujata, 1 second. Dr. Maya, can you please talk about the conference? I forgot. She had to talk about the new, the annual conference. Asmita, can you please show the flyer for the conference? Dr. Maya, please, can you just talk about the conference? Because, then, yeah, you have to welcome people to the conference.
Thank you very much. And sorry for interrupting this flow of cases.
No, my mistake. My mistake. I forgot to do in the beginning. So, yeah.
Thank you. Yeah, I would like to extend a warm invitation to one and all for our Child Neurocon 2024, which is our annual conference. So please save the date and try to attend it. We have 5 workshops on day 1, and day 2 and 3 we have exciting talks by various experts. So I would invite everybody to save the date and please come and participate in this conference. Thank you, Dr. Shefali. Thank you.
Thank you.
Thank you. Thank you so much.
Dr. Shefali, Dr. Kavita wants to come in. I think she has a problem with mic. Dr. Kavita?
Dr. Kavita, you can speak later if there's a problem with the mic. We will, but it was a wonderful case. Some problem from your mic, then you can log in from your mobile and then speak in between, I think. I think that you can do. By the time we can go to the next case, your comments we can have after the second case, I think. Yeah.
So we'll go on to
this certificate will be mailed. Yeah, this certificate will be mailed to you, Krishna Priya. Yeah. Sorry, continue, please. Yeah.
Thank you, Dr. Shefali. So we move on to the next case. This is the early infantile. Dr. Pujita. And our moderator is Dr. Ranjit Kumar. This is from SRIHER or SRMC Institute, Chennai. So here we go.
Sujata, you can see the time now. You see the time now for Ranjit.
Yeah, for Ranjit, I see. Right. Yes, can we start, please?
Am I audible, ma'am?
Yes.
Good evening, one and all. I'm Pujita, pediatric postgraduate from SRMC. My moderator is Dr. Ranjit, pediatric neurologist and epileptologist. Hereby, we are going to present an interesting case titled Mysterious Infantile Episodes Unmasking Paroxysmal Eye Movements in Seizure-like Guys. This is a case of a 3-month-old girl child born of non-consanguineous marriage presented with seizure-like episodes with a head and eye turning to one side, either right or left, for approximately 2 to 5 minutes, which are spontaneously aborted and associated with inconsolable cry for 20 minutes. approximately, and the birth history of this child was uneventful, and development-wise, the child is normal and immunized till date, and no family history of seizures. Examination-wise, the head-to-toe examination was normal, vitals were stable, anthropometry appropriate for age, and systemic examination-wise, CNS examination was normal except for mild axial hypotonia. Investigations done, basic investigations of blood counts, electrolytes, calcium, and magnesium were normal. MRI brain done was normal, and EEG done was also normal. And blood TMS and urine GCMS were also normal. The child was suspected with infantile onset seizures. In view of suspected infantile onset seizures, the child was initially started on syrup levetiracetam, phenobarbital, and oxcarbazepine sequentially, but there was no response to anti-seizure medications. These are the videos how the child presented to us. So this, as you can see here, the child is having the right side turning of the head and right sided turning of the eyeballs with the opposite side limb movements can be noticed over here.
You can go to another video, Pooji, the next video. Yeah.
This is also a similar kind of presentation, turning to the left side with the fixation of eyeballs to the left side.
With inconsolable crying.
Yes, which is associated with inconsolable cry.
Next.
Similarly, this time the child is having the fixation of the eyeballs to the left side and the head turning towards the left side with
Okay, next. Let's move on. Yeah. I think you can go to the possibilities. Yeah.
So the differential diagnosis we had were focal seizures and paroxysmal eye movement disorders, with the etiological possibilities having GLUT1 deficiency syndrome and pyridoxine and megavitamin responsive epilepsies, channelopathies, and neurotransmitter disorders. And clinical exome sequencing with mitochondrial testing showed ATP1A3 mutation on exon 17, which can be causing alternating hypoplasia of childhood type 2 and developmental and epileptic encephalopathy 99, which is autosomal dominant in inheritance. These were the genetic testing results. And the final diagnosis of this child is ATP1A3 channelopathy associated paroxysmal eye movement disorder. And the treatment-wise, the child, after the final diagnosis, was started on tablet topiramate and tablet flunarizine after discussion with the parents. And there is significant reduction in the frequency of the spells. In the last 4 weeks, the child had no spells except for one possible brief mild spell was there. And in case of further episodes of, we are planning to give the child oral ATP and ketogenic diet. Thank you.
Ranjit, your comments.
Thank you, Pujita, for presenting a nice case. So, in fact, the child...
Stop sharing your screen.
Yeah. So the child presented with recurrent episodes of paroxysmal episodes of this kind of eye deviation towards one side with inconsolable cry, lasting for 20 to 30 minutes, sometimes unprovoked episodes. And child remains conscious, but it is very difficult to assess responsiveness in such a child. tried on 2-3 AEDs, didn't respond. Multiple EEGs were normal. We thought whether it is a non-epileptic kind of an event, and we did the genetic testing, which showed ATP1A3. I haven't seen such a yearly presentation of paroxysmal eye movement in a child with ATP1A3. So far, the child has not had any presentation like an alternating hemiplegia or any other presentation. Fortunately, it seems the child is responding to flunarizine and topiramate. Although flunarizine we gave off-label, it's not like kind of recommendation is like not sure whether it can be given at such a young age. So that's the
Right.
yeah.
So can we open this now for discussion? May I ask
So
the
what was the video EEG like in this child? And was there any nystagmus, and how was the vision? These are the things one would like to find out.
No nystagmus, ma'am. And also we tried video EEG short term. These episodes never happened in hospital. All the episodes happened at home. So she was admitted actually thrice for 2 days each. We couldn't capture a single episode in the hospital. It all happened at home.
That's strange, no?
Mhm.
And how frequent were the events?
Once in every 2-3 weeks, at least 2 to 3 per week over 3 weeks period. It was not daily multiple episodes.
So I would say that the duration and just the video itself shows it is not an epileptic, but I think video EEG would have been really useful here. And was there any history of migraine in the mother, or something?
There is no history of migraine in the mother. This was a de novo mutation. Parental testing was
normal.
Negative. Yes.
Okay.
Often ATP1A3 is a de novo. Yeah.
So I don't want to take this. I would not want to take the message that you first do the genetic testing and not the video EEG, because I think that would have been the first step in my view. Dr. Taj, please, your comments on this.
Hi, yeah. So this is the classical presentation of AHC. So majority of the patients, babies do present before the age of 6 months. And you can see one of the most earliest presentation is the dystonic posturing of the neck with abnormal eye posturing. So usually the differential diagnosis, of course, our benign proximal upward eye gaze with tonic flexion, but babies tend not to be too irritable or restless or in distress. But in what do you call this AHC, majority of the times when they have these episodes, they start off with 40 seconds, 50 seconds, they tend to go up to 20 minutes. I've seen up to about 30 minutes with abnormal eye movement and tonic neck posturing. One of the what you call differential diagnosis is always the what you call neurotransmitter disorders, because the phenomenology itself is dystonia. It's a dystonia, oculogyric-like, manifestation, because you've got eye manifestation and also the neck manifestation. So it's actually a classical presentation of AHC. Majority of them present in this way. It's just that they are missed or during and after some time, as the disease progresses, you'll see this what you call manifestation evolving or metamorphizing into more of alternating hemiplegia-like pattern. But this is one of the earliest. It doesn't last long, probably about 6 months to 8 months or about a year. So we may get an artificial feeling that Topamax works or the flunarizine works. You can try both. You can even try aripiprazole or nifedipine, but after some time, they tend to worsen and then they evolve to something else. So AHC does present in this way, usually less than 6 months. One of the earliest finding, this is the one. Yeah. Thank you.
That was helpful. That was very helpful. Thank you.
Yeah. Thank you. Ranjit, you have 1 or 2 questions. You please read and answer fatafat.
Ranjit?
Yeah. So what is oral ATP? So this is involved in this is related to ATP pathway. So I think oral ATP is a drug which is tried in AHC with doing this mutation. Explanation of inconsolable cry. I think most likely paroxysmal spell causing dystonic kind of a crisis, maybe having a pain component also. The other gene ADRG is a variant of unknown significance. It was not significant.
Okay.
One question in the chat is there, why cannot it be a focal seizure by a pediatric, from a pediatrician point of view? So one question in the chat.
So the episodes are going for 20 to 30 minutes sometimes. And the child was conscious during the whole period, although difficult to assess responsiveness of such a young child. So based on the video alone or description of parents alone, I think focal seizure cannot be ruled out. So, but routine EEG done thrice was normal, although a normal EEG does not rule out epilepsy. So only way probably we could have captured a video EEG, which we could not, because like we tried many like short-term video EEGs, we couldn't capture.
Okay. If there are some other questions that they have,
I will write in the chat box. I will write in the chat box. Yeah,
that will be nice.
Thank you.
So-
Thanks.
Thank you so much. We move on to the next, the other early infantile one. Dr. Deepthi K is the presenter, and the moderator is Dr. Gautam Kamila. This is from AIMS, New Delhi. Please start.
Good evening, everyone. Today we are presenting 3 cases, startled and stiff, in a neonate, in an infant and a toddler. Case 1, 20-day-old male newborn who was born out of a non-consanguineous marriage and had no significant antenatal or perinatal insult, presented with the complaints of abnormal movements in the form of paroxysms of sudden stiffness of the limbs, occurring 20 to 25 episodes per day from day 1 of life. As these episodes persisted, the child was evaluated at multiple hospitals, and initially the child was diagnosed as a case of neonatal onset epilepsy, and he was started on anti-seizure medications like Levera and phenobarbital. As the symptoms persisted, he was also given a vitamin trial, keeping possibility of vitamin responsive epilepsy. However, there was no response. The child was evaluated extensively. The EEG did not reveal any interrectal epileptiform discharges, and MRI brain also did not show any structural abnormality. The initial metabolic workup, including TMS, GCMS, glucose, lactate, ketone, were also normal. As these episodes persisted, the child was referred to our hospital at day 20 of life. At our hospital visit, we reviewed the history and the home videos. Home videos mainly consisted of sudden jerk-like movements, which was precipitated by auditory and tactile stimulus. On further probing, the mother gave history of similar illness in the maternal uncle in the form of sudden jerk-like episodes and history of fall. The child was developmentally normal, and the growth parameters were also within normal limits, and there was no encephalopathy. On examination, when we did a nose tapping test, we found that there was exaggerated startle response and repeated episodes of stiffening of the limbs. And important thing to note here is the non-habituation of the startle response. In view of non-fatigable startle response, episodic stiffness, absence of encephalopathy with normal MRI and EEG, possibility of hyperexplexia was kept, and a trial of clonazepam was given, which showed a significant reduction in the stiffness and also startle response. Hence, we went ahead with the next generation sequencing, which showed a homozygous missense variant in the exon 12 of the SLC6A5 gene. Similar to the first case, we also encountered 2 more cases. The second case which was a 2-month-old infant presented with similar paroxysmal stiffening of the limbs from 2 weeks of life. The third case was a 2.5-year-old male child who was referred to our hospital for evaluation of intractable epilepsy. On history reviewing, he also had history of paroxysms of tonic stiffening noticed since day 1 of life, and in between the episodes, the child was completely normal. In all the 3 cases, we found that there was history of exaggerated startle response to sound and tactile stimulation. Developmentally, the child was normal. The head circumference was appropriate for age. General and neurological examination in between the episodes were normal. As I already mentioned, all these 3 cases were treated as refractory epilepsy and was on multiple anti-seizure medications, including vitamin trial, but there was no response. Before coming to our hospital, the child, all the 3 children underwent extensive workup, including MRI brain, EEG, CSF workup, metabolic workup, which were all normal. In all the 3 cases, possibility of hyperexlepsia was kept, and trial of clonazepam showed a significant reduction in the stiffness and startle response in all the 3 cases. Next generation sequencing in first case showed homozygous missense variant in the exon 12 SLC6A5 gene. In second case, homozygous pathogenic variant in the SLC6A5 gene at intron 3 was noted. And in third case, a heterozygous nonsense mutation in the exon 2 GLRA1 gene was noted, hence confirming the diagnosis of hyperexlepsia. Startle is usually a protective reflex. It appears as a sudden, involuntary, rapid, jerky movement of the body, which is evoked by sudden and intense stimulus. When this is exaggerated and abnormal, this is called as startle rest syndromes. Hypereplexia is should be used in patients who presents with an exaggerated startle response and associated with severe generalized or intermittent muscle stiffness. And this is usually misdiagnosed as a case of epilepsy or tic disorder in nearly 30 to 80% of the cases. As we already know, glycine is an inhibitory neurotransmitter. Any mutation which is affecting the glycine neurotransmission can result in hypereplexia. These are the common mutations associated with hypereplexia. GLRA1 is the most common mutation. This is seen in around 60 to 65% cases. In SLC6A5 accounts for 20 to 25% of the cases. The core clinical feature is exaggerated startle response to unexpected stimulus and stiffness. A neonate with hyperplexia may appear as an alert baby with reduced spontaneous movement and appears as stiff as a stick when held horizontally. Bedside head retraction reflex and nose tapping test is a useful clinical examination which elicits a non-habituating startle reflex. Coming to the management, Vigavano maneuver, that is flexing of the head and leg towards the trunk forcibly during an attack, is helpful in counteracting the hypertonia, and this should be taught to the caregivers and parents. Clonazepam is the drug of choice. The response rate may be as high as 86%. If the monotherapy fails, then combination of benzodiazepines like clobazam and clonazepam can also be used. This is a case. This is a case series which was reported from our institute. The key messages are: hyperexplexia is a close mimicker of epileptic seizures in infancy and in children. All our cases were initially misdiagnosed as refractory epilepsy. Hyperexplexia should be suspected in a child who presents with history of characteristic stiffening episodes associated with non-habituating startle reflex. A simple bedside nose tapping test is very much helpful. Even though hyperexplexia is a rare entity, but it is a treatable entity. So timely diagnosis can alleviate stiffness, prevent secondary complications, and also prevent unnecessary therapeutic trials. Thank you.
Is Dr. Gautam here?
Yes, ma'am. Thank you, ma'am.
Yeah.
So basically, the constellation of these three cases was to highlight the importance of bedside tests, like a simple bedside nose tapping test to detect hyperexplexia, and and also to aware the audience over here to make so that they have an awareness regarding this disorder, which is a rare disorder but not very uncommon to find in our clinical setting. And also, once we diagnose it, the treatment is very simple. Just giving a proper course of benzodiazepine may benefit the child. So that was the importance of this case.
Yeah, thank you. I will now open it to the experts. Ma'am?
I think it is a very nicely presented, fully worked up case and very clear messages. I don't think we should waste time. We have already overspent the time in this case. Dr. Taj, if anything to be added?
Yeah, so it's an interesting case as most of the cases are. So the most commonest mutation I've seen is the GLRA1, GLRAB, and the SLC6A5. So there are certain differentiating features in all these three. Myoclonus is very obvious in the GLRA1 and also the GLRAB variants, whereas the SLC6A5 does not present much with myoclonus, and you don't get that seizure-like manifestation. The stiffness like stick, the severe rigidity is more obvious in GLRA1 and also GLRAB, but not as much in the SLC6A5. And the Vigavano maneuver, I think the efficacy of this maneuver is overrated because I've tried it many times. I've got several patients, about five in my hand now. One passed away. So it's slightly overrated. So you might not be too over enthusiastic in trying to do Vigavano when the child is, is already very stiff and rigid, and the child, they may even turn blue because apneic episodes are very common. And commenting about apneic episode, be very careful because it was also mentioned the combination of clonazepam and clobazam should be tried, but be very careful because these GABAergic agents may promote or may worsen the apnea. Yeah, thank you.
Right. Thank you. Dr. Shefali, any comment?
No, we go ahead with the
Yeah,
next, please. Yeah.
Professor Tangavelu from Chennai has asked, can Tay-Sachs be a differential diagnosis? Dr. Deepthi.
Gautam.
No. Answer?
Am I audible?
Yes, Dr. Gautam.
Yeah, so yes, definitely the Tay-Sachs can be a possibility, and we had sent a genetic investigation in which we found this mutation. So because of the nose tapping test, the non-habituation part, the possibility of an hyperexia was higher up in this particular case.
Right. Thank you. We move on to the next case. This is the late infantile. The presenter is Dr. Apurva Gupta. Moderator is Dr. Ramesh Kunarki. This is from Rainbow Hospital, Hyderabad. Can we start?
Yes, ma'am, I'll share the screen.
Yes, thank you, Dr. Apurva.
Is the screen visible?
No.
While Dr. Apurva loads, we'll be having a quiz on epilepsy one of these days, and it will be sent out to everybody who's attending. So you will be free to join. There will be some very interesting quiz, yeah. It's not full screen, Apurva. Yeah, thanks.
So this is a case of a head drop. A 6-month-old boy came with complaints of sudden brief episodes of head drops from 1 week after an episode of febrile illness. These head drop episodes were multiple episodes in a day in clusters, present only during wakeful period, not present during the sleep period. Immediately after the head drop, the child resumed the activity. There was no impairment in consciousness during the episode. There was no loss of posture, no postictal period, no obvious triggers. The child had normal neurodevelopment and a normal examination. So this is the video of the child. So the approach to a head drop in a child, these head drops could be epileptic and non-epileptic. Epileptic head drops are usually associated with impaired responsiveness during the period. There may be interruption of the ongoing activity. Around the time of the event, there may be autonomic changes, some bluish discoloration, eye blinks, change in facial expressions, some slackening or some drooping of the facial expressions. They are usually present in clusters. Epileptic head drops may have diurnal variations. There may be more in early morning, and they may have associations with sleep-wake cycle. Epileptic head drops, the children may sustain some injuries. There may be associated loss of upright posture and developmental delay. Whereas non-epileptic head drops, they are usually having no distress or impairment in consciousness, no postictal period, and usually they have a normal development. So the differential diagnosis that were considered in relation to head drop, these are the movement disorders, sleep disorders, axial muscle weakness, and epileptic head drops. So tics, choric syndromes, paroxysmal dyskinesias may present as head drops, but they are more stereotypic repetitive movements with some trigger. Sleep disorders, again, these are attacks which happen in sleep, and they may be sudden loss of muscle tone presenting as a head drop, and they may be associated with excessive daytime sleepiness. Axial muscle weaknesses in the form of axial myopathies may present with head drops. Difficulty in raising from bed can be the other issue associated. And then certain epileptic conditions can present with head drops, which may be atonic variants of benign epilepsies, Lennox-Gastaut, Dravet syndrome, in which there may be seizures, cognitive impairment, and developmental delay. The important investigation is EEG. In all the cases of movement disorders, sleep disorders, and axial muscle weakness, there may be a normal background. And in epileptic head drops, there may be characteristic finding depending on the different type of epilepsy. So this is the EEG of this child to record the event. So during both the episodes of the head drop, there was no ictal correlate. There was normal background, normal sleep markers, no interictal discharges, and there was no ictal EEG correlation. So this is a case of a benign spasm of infancy. These are sudden paroxysmal movements, which are typically present during wakefulness, characterized by spasms. They may involve sometimes only the head, neck, but they may involve trunk, shoulder, and upper extremities. The duration of attack is usually very brief, 1 to 2 seconds, and usually there is no impairment of consciousness or any distress and no post-ictal period. EEG is important as it is going to capture a normal event during and in between the spells. These episodes are usually self-limiting. They occur in the late infancy, and by the end of 1 to 2 years, they subside on its own. And the development is usually normal, and no treatment is required for these episodes. This is another case, the EEG of another child, which is on the same day with mild developmental delay and had episodes of head drops. So as opposed to the previous EEG and the video correlate, in this there is along with the involvement of the head drop, there is a truncal muscle involvement in the upper limb involvement, and EEG correlate suggestive of ictal discharge. So this was a case of a benign myoclonic epilepsy. Thank you.
Ramesh?
No, ma'am. I think she presented everything well. So the diagnosis for this case, index case, is benign spasms of infancy, which is a very ill-defined entity. Earlier, people also the features overlapped with benign myoclonic epilepsy of infancy, but the myoclonias are much briefer and much milder in intensity, just the subtle neck movements or shoulder movements, whereas these look more like spasms. So maybe benign spasms of infancy is a more appropriate term, although the spectrum of benign myoclonic epilepsy is little broader.
Right. Dr. Neja, ma'am.
I think it was very clear. It was video EEG and she showed a differentiation between a true, benign myoclonic epilepsy as well as, so very well done. So I think we can move on to the next one. I have nothing to add here.
Dr. Taj.
I probably would consider this as a spectrum of benign myoclonus of early infancy. There is a certain rhythmic component to the child's movement, and there's certain what they call voluntary or semi-voluntary component. The child is very cheerful, very active, continuing with the activity immediately. And if you can watch the video again, you'll see that when the child is trying to grab something, he still has the head drop again. So there is a certain what they call a semi-voluntary component in there. So it will be a spectrum of the benign myoclonus of early infancy. The benign spasms of infancy is probably too ill-defined for us to conclude as a diagnosis, but at the end of the day, the prognosis is still very good. The child develops normally. But some of them may have mild hypotonia in the very early stage, but later they develop normally.
Right. Dr. Shivali, anything?
No questions.
No questions, Dr. Ranjit? Great.
No questions.
Thank you. Very nice. Can we move on, please? We have the next case. It's a toddler. Dr. Vikas K is the presenter. Dr. Venkataraju is the moderator. And this is from Indira Gandhi Institute of Child Health, Bangalore. May we start? Dr. Vikas?
So while he's coming up, we have maximum number of participants.
Yeah, am I audible? 271, yes.
275 participants, and if you have noticed, we are going from age-wise. Neonate, now we are moving to toddler.
So you mean the presentations are toddler, or you're saying?
No, presentation is a toddler.
I know. We have only designed it. I know. I was just talking about the participants. Fine.
Is the number now.
I know. It's fine.
Amazing.
So I'll say, no.
Amazing.
Yeah, Then the cases are nice. Yeah, everybody's nice. Actually, we didn't want to say no. And actually, I was just requesting all of you to please join for the quiz. We will making a platform we had done earlier 2 years back. We'll come up and very soon it will be shared because we're looking for that platform again. You have to purchase that platform. Yeah, please continue, please. Share. Who was sharing?
Can I go ahead with the presentation?
Yeah,
Veena,
because
please.
Can I go ahead with the presentation?
Yes. We were just
Yes.
talking in between only,
Yeah,
na.
I'm Dr. Vikas. I'm pediatric neurology fellow in Indira Gandhi
You
Institute.
please share
I'm
your
working under
slides.
Dr.
Please show your slides. We can't see the
Yes, show your slides. Yeah.
Yeah. Just a minute. Just a minute.
Yes, take your time.
I think we distracted him. Ranjit, you should not interrupt him.
But 275 was exciting.
Just a minute. Is it visible?
It'll come. Yes.
And Ranjit, please note down the titles also now for these cases also.
I would like to present a
Full screen karo, beta.
6-year-old
Full
boy
screen.
presented from
Full screen. Beta, Vikas, full screen nahi hai.
Yeah. Is it okay, ma'am?
Sir, it's
Beta,
still
it's
in
not full screen.
editing mode. Still in editing mode. Click on the fifth.
Is it okay now?
No.
Not sir. No, sir. It's in.
You have to go down and press that.
Click on the fifth menu.
Slideshow. Slideshow.
Is it okay?
No.
No, it's
The
not
slideshow, the one which is.
Yeah.
Continue like this. It's all right. Don't
I
waste
think
time.
let him continue like this. Yeah.
Yeah, continue. The only thing
I
is
would like
video.
Video won't run.
Yeah.
It doesn't matter. We'll come back. Start till then.
Ma'am, is it coming now?
No, Dr. Vikas, you can continue presenting.
Yeah. I would like to present a 6-year-old boy presenting from Bangalore. He presented with episodes of paroxysmal events starting at 3 months of age and also had developmental delay associated with it. So the child had a normal birth history at 3 months of age, presented with paroxysmal episodes of generalized posturing, each episode lasting for 2 to 3
Change your
minutes.
slide. Slide is not moving.
There is an issue with this thing.
Vikas, 1 second. She stopped sharing. It's okay. You can share again. Yeah.
First, put it on slideshow mode, then share your screen.
Yeah. First, put it on slideshow, then you can share.
It's okay, ma'am. No?
Vikas, go to the top panel on the fourth. It's written slideshow. Click on that.
No, just
Abhita, while he's trying to figure out, you can make your comments on your short sample. You got your voice back.
Yeah, I joined from mobile actually.
Yes.
Yeah, I got it. Yeah.
Laptop.
Yeah.
Yeah, so that
nice
case was really very intriguing for us initially. And the baby kept on having these stiffening episodes, but that pursing of lips and blepharospasm, that was really intriguing because that was not fitting in any seizures or any other known movement disorder. So that's why we had this doubt of myotonia. But when the EMG came negative, we were a little disappointed. But then when we read the further literature, it was proven that we may not get myotonia. And of course, the exome then solved the issue. But by that time, the baby had already succumbed. So that's all from my side.
Dr. Vikas, is it possible to share? Asmita, can you help him, please?
Hello.
Can you please help him?
Hello, Dr. Vikas.
Ma'am, just a minute. Yeah, ma'am.
Yeah, first open your PowerPoint.
Yeah.
Put it on slideshow mode.
Yeah, ma'am, it's on slideshow.
Then hit the share screen button.
Yeah?
Share screen.
Share screen, the green icon.
Yeah.
And select the PowerPoint, which is in slideshow mode. That
You should do this before. You should do before from 7:30 to 7:55. You should do all this.
Ma'am, is it okay now? Is it coming now?
Your
No.
Zoom window has come, not the presentation.
Now?
No.
Okay.
You can share me your presentation.
I think we can go to the next one and
Yeah,
I
I think we can move on to the next. Are you ready?
Yeah,
Dr.
Vikas, you please,
Chaitanya?
1 second. Vikas, you mail to Asmita. She will share it. Meanwhile, Dr. Sujata is going to the next. Okay, you can present after this. Yeah,
Don't
you already
worry, Dr.
wasted enough
Vikas.
time.
We will come back to you after this case. Okay.
Don't worry. You just send the slides to Asmita.
Yeah. So now we go on to the next one. This is Dr. Achanya ready?
Yes, ma'am.
Okay, great. So this is a childhood age group. Dr. Achanya P is the presenter. Dr. Indra Kumar Shirawat is the moderator. And this is from AIMS, Rishikesh. So can we start?
Yes, ma'am. I'm sharing my screen.
Great.
Ma'am, is my screen visible?
Yes.
Good evening, all. Thank you for this. Thank you, AOCN, for this opportunity. I'll be presenting a case of tics mimicking as paroxysmal dyskinesis from AIMS Rishikesh under the guidance of Dr. Prateek Panda. We have a 9-year-old boy, developmentally normal, presented with history of multiple episodes of paroxysmal movements for the last 6 months. It had increased in frequency and severity since last 15 days. These movements were sudden, rapid, repetitive, abnormal movements involving both proximal and distal body parts of bilateral upper and lower limbs. There was also total shrinking and grimacing movements. It was lasting for around seconds to minutes, and it had aggravated during stress and emotional state. These movements were absent in sleep. These movements were also preceded by an urge, and the child was able to suppress these movements momentarily. The movements followed a similar pattern and had a fluctuating course throughout the 6 months. He had no, it was also associated with recurrent episodes of throat clearing sounds, but he did not have any history of coprolalia, echolalia, or palilalia. In the last 6 months, the parents also noticed that the child was unable to concentrate on reading, is distracted easily, is unable to sit seated in a place for a long time, talks excessively, and doesn't wait for his turn. It was present at home as well as at school. He had no history of loss of consciousness, uprolling of eyes, or frothing from mouth, no history of any bowel or bladder incontinence, no prodromal febrile illness, sore throat, or vaccination. There was no history of any twisting or flinging movements or any gait abnormalities, and it was not associated with any cognitive decline. The child was treated for these movements as seizures outside and was on levetiracetam at 20 mg per kg per day. And he was referred to us in view of non-improvement. The video of the child, in which we can see that there is sudden, rapid, abrupt, involuntary movements, which are non-rhythmic, complex motor movements, and some dyskinetic movements as well, which is involving bilateral upper limb and lower limb, and both proximal and distal movements, which is lasting for a few seconds. These movements were preceded by an urge, and we can see that he's able to suppress these movements voluntarily and on command for a brief period. As per history, he also had episodes of throat clearing, and these movements were absent in sleep and was aggravated by stress. We consider the following differential diagnosis for this child. So our first differential was complex motor tics, as a child had sudden, rapid, repetitive, and non-rhythmic movements, and there was also history of vocal tics. These movements were preceded by urge, and it was suppressed voluntarily for a brief period.
these movements had a waxing waning course, and it was absent in sleep and was aggravated by stress. A close differential which we considered was paroxysmal non-kinesiogenic dyskinesias, as this child was having hyperkinetic movements lasting for a few seconds to minutes, and it was triggered by excitement and stress, and he also had a premonitory urge. However, these movements were suppressible, which was against PNKD. Paroxysmal kinesiogenic dyskinesia was also considered, as he had hyperkinetic movements lasting for seconds to minutes and had a premonitory urge. However, these movements were not triggered by sudden voluntary movements.
Time up.
Other differential considered was Sydenham chorea and anti-NMDA encephalitis and Wilson's disease. So on evaluation, his serum calcium, ceruloplasmin, and TFT ASO titers were normal. The MRI brain done outside was normal. The anti-NMDAR receptor antibody was normal. A video EEG with suggestion was done, and the event could not be reproduced. On evaluation, he had a CBCL T-score of more than 60 for inattention and had satisfied DSM-5 criteria for ADHD. And his full-scale IQ by MISIC was 88. So the diagnosis was ADHD combined type, inattention and hyperactivity with provisional tic disorder of complex motor and vocal tics, as it was less than 1 year. And he was started on clonidine at a low dose, and the levetiracetam was tapered and stopped. A recent aggravation of tics since last 15 days, for which the stressor of exams was identified, and behavioral therapy was also carried out. Upon follow-up at 3 months, the tics had reduced in frequency and severity, and there was also improvement in ADHD symptoms. Thank you.
Thank you. And do we have Dr. Inder Kumar?
Dr. Inder is traveling currently, and so he has some internet issues. So he requested me to
Yes, please. Please carry on. You may
Ma'am, the only thing I wanted to add is there were 4 more videos. Actually, I contacted the practitioner who started levetiracetam. Why did he start? So he told there are 4 more videos, and actually they were due to sleep disordered breathing and something like that. There were periodic limb movements. So they combined these things and they started levetiracetam. So one thing I wanted to comment is, whenever there's a tics, we should always rule out ADHD and this sleep, and you should always do a PSG. Periodic limb movement syndrome is quite common. That is one thing which I wanted to add.
Thank you. Thank you so much. That was useful. Dr. Neja ma'am, Dr. Tajul.
Hi. So the phenomenology itself, basically, it's more like complex. It's a complex phenomenology. It will be erroneous for us to call them as dyskinesia, because it's a very repetitive, rhythmic movement. So dyskinesias are usually referring to choreoathetosis or choreiform movement with some dystonic posturing, so can be confusing that part. And when he's the entire repertoire of movement has stopped, and then he has got this restlessness-like movement of his leg. So this akathisia-like or restlessness-like presentation is, if there is no history of associated drug, what you call exposure, I would always think of children with ADHD or ADD who are hyperactive or hyperkinetic phenotype. The differential diagnosis of PNKD and PKD probably doesn't sit very well, because the phenomenology is slightly different for PKD and PNKD. They're very much choreoathetotic or dystonic, rather than what you call very stereotypic movement. These movements are very stereotypic. They're repetitive. They're almost similar. There's some rhythmic component in that. So probably not PKD or PNKD, but more towards ADHD with what you call complex motor tics or akathisia-like presentation. Or some of these children may also have some OCD. So the compulsion itself kind of overlaps with the urge, which they may not be able to pronounce very clearly out now. So it's always an overlap. Is there any clinical features of OCD in this child?
Sir, we could not find, but I think we will again inquire about all the child, and we will at that time we could not find any features of OCD, sir. But we will again inquire, sir.
Inshallah. Okay. Thanks. Good case. Good case.
Thank you.
Yeah, very good case. And I think again I would highlight the presence of comorbid, psychopathology in these children, especially because he is also IQ is also at the border, and I think this obsessive OCD, as they said, is very, very important to. Maybe it will also can come later on also. It may not be obvious right now. So I think very good case and very interesting case. Thank you.
Excellent, very nice cases, yes. So can we go back to Dr. Vikas? Dr. Ranjit?
Yeah, he's sharing the screen.
Yeah.
Yeah.
Is it coming, sir?
Yes, yes.
Carry
try-
on.
Carry on, yeah.
Sir, I share your slides.
Is it coming now?
Because start speaking. Asmita is going to share the slides. You start speaking. Yeah.
Sir, I think I've shared my screen. Can you just check, sir?
Dr. Vikas, let Smita
Yeah.
do it, please.
Because it's not full screen as yet. Can you just try once more? Then you stop sharing.
Yeah, ma'am. Is it okay, ma'am, now?
Nobody will be allowed to present till they have done a practice between 9:30 and 7:30 and 7:55. Because
Ma'am, is
it
it okay
wastes
now?
so many persons'
May
time.
I request
Yeah, stop
Asmita?
sharing.
Yeah, please stop sharing and let Asmita share, please. Or we'll have to
Can't
move
stop
on to the
sharing.
No, it's okay.
Perfect.
Yeah.
Perfect. Carry on.
Sir, please start.
Thank you,
Yes,
Asmita.
ma'am.
Yeah.
Next slide. Yeah, I would like to present a boy, 6-year child from Bangalore, presented with paroxysmal episode starting at 3 months of age and had associated developmental delay also. Next slide. So there were two sets of paroxysmal events. Initially, he had episodes starting at 3 months where it was a generalized tonic posturing of all 4 limbs associated with uprolling of eyes and had a significant post-ictal drowsiness each episode lasted for around 2 to 3 minutes. And these were multiple episodes occurring in clusters. These were seen both in sleep as well as awake state. Had around 3 to 4 such clusters in a span of next 2 months, and last episode was around 7 to 8 months of age. So from there to around 3.5 years, the child was relatively okay. And for 3.5 years of age, the child started having brief episodes of sudden tightening of all 4 limbs, involving the face as well as the limbs. Each episode lasted for about 30 seconds to 1 minute without any significant post-ictal drowsiness. Child used to have around 10 to 12 such episodes every day. And currently, after our intervention and medications, now it's reduced to around 2 per month. So these episodes occurred only in awake state, point to be noted, and occurring any time of the day, especially when the child tried to initiate movement and tried to play with toys or feed self. Next. So as we can see, a child had a mild developmental delay, predominantly affecting the cognitive more than the motor milestones. Next slide. Yeah, next. So child also had a significant family history where even the father had similar episodes at around 6 to 7 years of age, which was not significant enough to consult a doctor. So around 12 to 13 years of age, that was the last episode, and also had a history of migraine. And even the mother also has a history of headaches, which are suggestive of migraine. Next. So these were the videos. First video, please.
Smita, your slides are not synced.
Vikas should play the video from his, maybe.
Because I can show the videos with Dr. Vaikuntra just sent to me. Do you want me to
Yeah,
share? Let me try. Just tell me which one is yours. This one?
No, sir. The other ones. Down.
You want to see this one?
Yes, sir.
This session, no?
Can you see that? You can describe the video.
7:30 to 7:50.
As we can see in the video, child had paroxysmal episodes involving choreoathetosis and dystonia, as well as involving the limbs as well as the face. So the child, as we can see in the video, is also conscious during the episode, seeing around, and episodes are brief with no loss of consciousness. And this is one more sibling of the child which was affected of same simiology. These are again brief episodes occurring only in awake state.
Okay. Yeah. I think you can speak about your diagnosis
Slides, please.
and wind up. Yeah.
So this child's head size was around normal, and the examination had mild autistic features with a relatively normal CNS examination. Next slide. With these differentials, DE was a possibility with initial presentation of clustered seizures in the infancy, but gradually the episodes reduced and there was no significant developmental delay associated with it, so like less likely possible. Channelopathies was a possibility because there was a brief episodes occurring only in awake state and no significant developmental delay. GLUT1 deficiency was also a DD, but there was no associated ataxia, no significant delay, no relation to food intake. Neurotransmitter disorder was a rare possibility, but no significant tone abnormalities. The tone abnormality which we saw here was only brief and no diurnal variation. So are most likely in these DDs were channelopathies. So we did investigations, routine investigations with the metabolic workup, MRI and EEG, both were normal. Next slide. So as we can see, EEG as well as the MRI are relatively normal. So we sent a whole exome sequencing which revealed a homozygous PRRT2 mutations. So our final diagnosis, developmental delay with epilepsy, autistic features, paroxysmal dyskinesias with a significant family history of migraine and dyskinesias, secondary to PRRT2 mutation. I just want a minute to explain about the experience in our center. So next slide. So we tried with two medications. Initially started with valproate, no significant improvement were noted, and we started carbamazepine, which was the second medicine, and the child had significant improvement, and no such episodes were noted in the past 6 months of follow-up. Next slide. Next slide. Next slide. So from these things, PRRT2 mutation usually present with self-limited seizures in infancy, normal development with the paroxysmal dyskinesias in childhood with a significant family history of seizures or dyskinesias or migraine. One more thing we need to know, homozygous variants tend to be more severe and they tend to have more problems. Next, please. So they have refractory seizures needing more than 2 anti-seizure medications. They had delayed developmental milestones might be delayed. Homozygous mutation tend to have more frequent PKDs and difficult to control. So there is an importance of differentiating heterozygous as well as homozygous traits. Next slide. So homozygous, as I said, developmental delay, behavioral abnormality, refractory seizures.
Time up. Please go to your
Next slide.
Yeah.
So this was the experience from our center. We had around 22 such cases of genetically proven PRRT2 mutations. There were female predominance with significant history of seizures in all the children, with 30% presenting with paroxysmal dyskinesias and 31 having developmental delay and 19% having both. EG was majoritarily normal around 60% of the cases, and all of them had significant family history around 64% of the cases. To our surprise, 35% of the children responded to phenytoin and valproate better than carbamazepine, which were the routine medications which we use. That was the one finding from our study. Next slide.
I think
These
we've
were the cases.
gone beyond the.
I think,
Yes,
yeah, time up.
we
Please,
move on,
Ashmita, stop sharing the screen. Yeah, go ahead.
because it really won't be fair to the others. Short comment, sir, ma'am.
Before that, Raju, ma'am, Raju, he's there. Raju is there.
Yeah.
Good evening, madam. Yeah, good evening. So in this case series, you need to know that whenever a child with seizures, so it comes with a different similarity of movements, you should always consider this condition as a possibility. And usually heterozygous is commonly described, but homozygous condition can be present with significant developmental delay and seizures and autistic features. So this condition should be considered. Thank you.
Thank you. Interesting. Very interesting. You have a lot of work there. We just saw.
Thank you. Thank you.
Yes, Madam, sir.
I don't think we should move on. I think that's very self-evident.
I
But
think
Taj
maybe
wants
Dr.
to say.
Tajul.
Dr.
Yeah,
Tajul wants
please.
to say.
Yeah, please.
Yeah. So we'll go on to the next case. This
Dr.
is
Tajul will say something. Dr.
Yes, sorry,
Tajul.
yes,
Dr.
yes.
Taj.
Yes, Dr. Tajul. He's just putting a thumbs up. He's fine with this.
Okay, go ahead.
Right. So we move on to the next case. The presenter is Dr. Reshmi Ravindran, and the moderator is Dr. Mary IP. It's from Trivandrum Medical College. So we'll start. Dancing shoulder.
Please start, Dr. Rashmi.
Is she muted or something? No.
Yes, I was muted, ma'am. Sorry.
Okay, please start.
Good evening, respected faculty. Today I'll be presenting a case of a girl with dancing shoulder. Coming to the case scenario, she was an 11-year-old girl child referred to as or institute as focal seizure from local hospital. She was developmentally normal, who had presented with acute onset, repetitive to and fro movement of right shoulder, it was seen intermittently for 2 days prior to the presentation, and each episode was lasting around 5 to 10 minutes, and all events were occurring only during wakefulness, and there was no history of urge before the events, and there was no history of altered sensorium, loss of consciousness, or loss of memory during these events, and no significant past history was there. And she was studying in 6th standard with the average scholastic performance. With this history, the DDs we had considered were focal seizures, tics, and segmental myoclonus. And coming to the examination, her vitals were normal, higher mental function were normal, cranial nerve examination was normal, fundus was normal. Her bulk of muscles were normal and symmetrical, normal symmetrically bilaterally, and particularly we had looked for wasting of shoulder muscle groups like in infraspinatus, supraspinatus, rhomboids, pectoralis, deltoids, and teres. Since we had considered segmental myoclonus as a DD, and we had looked for wasting in these muscle groups, and her tone were normal, power was normal, and dependent reflexes were normally elicited. Her plantar reflex were flexor bilaterally. There were no sensory deficit and no cerebellar signs were there. In this video, we could clearly see the non-rhythmic repetitive to and fro movement of the shoulder with varying frequency. And once she is getting distracted with arithmetics or distracting questions, we could see considerable reduction in the frequency of these movements. And we could see these movements closely here. Here we could see that the humerus head is being partially pulled backwards and again back into the shoulder joint, and the acromion is getting visible. So after the examination, the differences we had considered were conscious dislocation of shoulder joint, tics, and segmental myoclonus. Since there was waxing and waning of frequency of these movements, and getting subsiding with the distractions, tics were still a possibility. But since we could clearly see that humerus head being partially dislocating, we considered the conscious dislocation of shoulder joint as the primary DD. And segmental myoclonus usually is more rhythmic, and here it is rather non-rhythmic, and it will be almost rhythmic, and rather than contraction of a group of muscle or a muscle is seen in segmental myoclonus, and hence that is kept as a lower DD. And investigation considered where MRI brain with a circuit vein, considering our DD of secondary myoclonus and EEG to look for evidence of focal seizures, and the serum calcium, serum ceruloplasmin, ANA, ESR, and ASO levels to rule out other systemic causes for neuropsychiatric manifestations. However, on a placebo treatment and suggestions, there were complete disappearance of these movements. And finally, we had concluded it as conscious dislocation of shoulder in a child with habitual shoulder dislocation. And these movements had recurred, and she had to visit our OP after 2 weeks. And on further probing, and on further probing, there were social stressors at school were identified, and after weeks of behavioral therapy and counseling, our movements had subsided completely and hasn't occurred since the last 9 months. Thank you.
Thank you. That was quick. And is Dr. Mary there? She'd like to say something.
Yeah, that was a smart diagnosis made by Dr. Rashmi in the casualty. Actually, in the casualty, she made the diagnosis of conscious dislocation of the shoulder joint, and she has presented.
Very nice.
Outside it was diagnosed as seizures.
Oh, right. Okay, we open this to the experts.
So it's sort of, it's a psychogenic non-epileptic movement, Dr. Mary. So psychogenic.
This was a conscious dislocation of the shoulder joint made by her for ends to be achieved because of the stressors in her life. Possibly we could call it BLES also.
Yeah, it is not psychogenic. You mean it is volitional and
voluntary.
Voluntary. Okay, and how frequently was it?
Pardon?
How frequent was it, and when you were treating it? Was it throughout the day, or what was it? The frequency, I forgot what was the frequency. Just to highlight to the...
Rashmi, what was the frequency?
Multiple episodes, more than 20 times were occurring during those 2 days. Before the child presented to our casualty, it was occurring quite frequently. Intermittently, it was occurring.
Right.
And it was the right side. So was it affecting her, the function?
No, madam. There was no restriction of movement or there was no affection of any functions were there. She was
The
able
mother
to
was
continue
very
writing.
distressed. Mother was concerned and distressed.
Yeah.
Okay, that's surprising because she was dislocating her shoulder, but nothing was affecting her actually. That means.
Looking quite comfortable, yes.
Anyway, Dr. Taj, it's very interesting, and how the children can present.
It's an interesting phenomenology, and I have seen multiple cases as such. So one of the few questions that we need to ask is with regards to the urge. Is there any urge for her to execute such movement? Sometimes this urge can be tricky because most of our Asian kids are unable to express that urge. But the Caucasian kids are smarter, and they tend to give all sorts of very objective and creative answers. But our kids, they will just shrug the shoulders and say, they don't know. But one of the ways to differentiate that is, from the phenomenology that this is semi-voluntary because with distraction, it tends to reduce. So there is some voluntary component, could be, overlap with some semi-voluntary component. So when you ask the child or subject the child with a certain task, which needs high concentration, an absolute psychogenic movement may stop or may alter significantly. Whereas a semi-voluntary movement with persistent urge, the task might halt and she may continue with such movement to execute, to quench the urge, and then continue with the task. So these small, maneuvers or small measures that we do may be able to differentiate, but at the end of the day, it still can be very difficult if the age is probably somewhere between 5 to 7 or 8 or 9, but bigger children could be easier. So my differential, motor tics or psychogenic movement disorders. Segmental myoclonus, very unlikely because one, it doesn't reduce with distraction or some focus task. Second, segmental myoclonus is very rhythmic. It's never rotatory. This is a very rotatory movement. So it's not segmental myoclonus. Segmental myoclonus is faster, rhythmic, sharp, and very rapid, and the frequency is high. Thank you.
I think that was very great, that what you described about the semi-volitional and the voluntary one. I think that is a take-home for all of us. This is important to distinguish because the treatment and the psychotherapy might be a little different in psychogenic. And I think lots of stressors. As you said, children may not express, but you need a very good history and a good psychologist to get it out. I've seen lots of children who had some kind of sexual abuse and some bullying who come with many of these movements, but they are generally purely psychogenic, I would say, not volitional as you or semi-volitional.
And we may need to see them multiple times in
Multiple
multiple
times,
clinical
yeah.
settings. Yes. Yeah.
And I need to highlight this, emphasize that they are more difficult to treat actually. They are really difficult to treat.
No, but actually, they come with widespread, manifestations, all these psychogenic ones, and we have done a lot of studies on that and some case series and all, and we have found stressors, yes, and a house tree person test, we found it useful. And Dr. Taj, one thing I would differ, it's not that our children are less understanding, they are less forthcoming. It is really very difficult. I mean, they just don't want. Why? Because they don't want to accept it. I mean, maybe because of the societal things and all. I think it's not about the children, it is because of the thing, like, they don't understand. Even like we've had patients, the parents refuse to understand the psychogenic component, trying to keep explain them. So it becomes a, that I feel, I mean, that becomes a problem, for it's more important for the parents also to understand that there is no organic thing in that, sometimes and it happens in various manifestations of functional, not only as for the seizures and point of view, not the PNE, but the other kind of functional things. But I think it's very it's a good
But when you
learning
look
for
at it
all of
in the
us.
other, when you look at it on the other aspect, it's actually not too different, because in a child who has got urge, it's an unexplained urge which is more, dopamine mediated or dopamine basal ganglia involved nigrostriatal pathway. But when a child who's got stress, there's also a form of urge, which is making a plan for the child to execute certain movement, probably to harness certain form of attention. So not sure how different they are or how similar they are. They could be two sides of the same coin.
I agree.
Right.
I agree.
Good
I agree.
discussion. Good
Next,
discussion.
next.
Yeah, we move on to the next. Is Dr. Anju Cherian there?
Share my screen.
Yeah, Dr. Anju. And the moderator is Dr. Mini. This is from Trivandrum Medical College. Please start. Oh, we have lots of dance.
Screen visible?
Yes, please start.
Okay. So I present the case of 11-year-old male who is referred from local hospital as suspected seizure disorder. His events were jerky movements of the abdomen lasting for around 10 to 15 minutes, associated with hissing noises. And these movements were occurring on a daily basis for the last 2 weeks before he presented to us. And the mother had complained of reduced responsiveness during these events. And the events only occurred during the awake state. He did not have any tonic-clonic limb movements, uprolling of eyeballs, loss of tone, fall, involuntary micturition, or defecation during these events. There were no triggers like sudden movement, emotional stress, or exertion. There were no premonitory sensations, and his neurological examination was normal. So this is the video. So these were bizarre hyperkinetic movements, which were characterized by repetitive movements of the abdominal wall, which was not very rhythmic. It was not painful. He also had hand-wringing movements associated with it. And there was some kind of vocalization with hissing noises. This is another video. So in the background of this video, there's a TV playing, and we can see that his movements are distracted when he listens to what is being played in the background. So it is not very stereotyped also because the frequency also differed in this. So what we considered were complex motor tics. Tics are sudden, repetitive and non-rhythmic movements which can be suppressed voluntarily for a brief period, and they are usually preceded by urge, and they have a waxing and waning course. But here he did not complain of any premonitory urge, and it was not very stereotyped also, as in the second video, there were no hand-wringing movements associated with the, which was seen in the first video. The other possibilities which were considered were paroxysmal dyskinesias, PKD and PNKD. These are also hyperkinetic movements which are usually triggered by excitement or stress. PNKD is triggered by excitement or stress, and PKD is preceded by sudden movements. But here there was no trigger, and usually in the paroxysmal dyskinesias, the movement is either chorea, dystonia, balismus, but here it was more of an abdominal movement. The other two DDs which we considered were psychogenic non-epileptic form seizures or malingering. It is very difficult to differentiate between these two, but PNES usually has an involuntary component also, whereas malingering is purely voluntary. So we did the routine examination. He had no KF-ring. His baseline investigations, including serum ceruloplasmin, ESR, thyroid function test, serum calcium, and ASO titers were all within the normal limits. We did a video EEG because he was referred as a seizure disorder. It was normal. We gave him some verbal suggestions during which the similar movements were replicated without any EEG correlate. So he was counseled by a child psychologist, and he actually accepted that his movements were voluntary because he felt that his parents had two younger children and he was not receiving enough parental attention. So we finally concluded that it was malingering and not PNAS. He did not have any events during hospital stay. So we did not do any further evaluation. He would be followed up in our behavioral pediatrics unit and pediatric neurology department. Thank you.
That was really short and sweet. And is Dr. Mini there?
Yeah.
Hello, Dr.
Yeah,
Mini.
nothing more to add. I think Dr. Anju has presented it very nicely. I would like to get the expert opinion on this because we are already late.
Yes. Ma'am.
So I think the very nice case, Dr. Mary, but these cases of malingering, a lot of, I think, stigma and shame also attached to all these things. How do you, I mean, you need to really, the management is a lot of sensitivity required for this, and talking to the parents, counseling, this becomes a real tough part for these cases. Otherwise, I think the video EG was clinching, and your psychological evaluation clinched the diagnosis. So diagnosis is very clear here. So thanks for presenting such nice cases. I think all cases were very good. The only thing I want to say is
we have one more.
goodness. Okay. I think Dr. Taj, if he wants to add to anything.
Taj to
Yeah, so
because Dr. Anju
such
had told belly dancers movement. I would like him to comment on the belly dancers dyskinesia also, how it differs from whatever we have seen.
Such abdominal movements are common presentations of motor tics in children. We see it very frequently. And one of the differential diagnoses, as you have mentioned, is belly dancers dyskinesia, but the phenomenology is clearly different. In belly dancers dyskinesia, what you see is actually an undulating movement of the abdominal wall. You don't get such jerky movement which are more myoclonic in nature. So when you get such movements which are more myoclonic in nature with what you call hissing sound or sudden expulsion of air through the mouth, you need to suspect things like diaphragmatic contraction, phrenic nerve irritation, or spinal cord issues, or sometimes pontine issues can present in such way. Whereas belly dancers dyskinesias, once you see it, you never forget it. I mean, it's of course the belly dancers himself, or I've seen two cases, both presented with the pontine myelinolysis, secondary to correction of the sodium, abrupt correction of the sodium. They're very undulating and they are almost continuous. They do not stop. They're definitely not distractible, and the what you call the nature, the amplitude of the movements are almost consistent and persistent. Whereas in motor tics, although like I just mentioned earlier, most of our kids are not able to enunciate the urge or the pain or the discomfort or distressing feeling, but most of our patients present with such movements are variants of motor tics. They tend to disappear. But of course, yes, psychogenic movement disorders or malingering, acting could also be a differential diagnosis. all leads to one form of treatment, which is behavioral treatment. Yeah, but the phenomenology is different. This is myoclonic in nature, very rapid, very fast, very dense dyskinesia, very undulating. It's very wavy in nature. So that would be able to help us to do a different.
What about propriospinal myoclonus? What will be their phenomenology like? Any comment from you, Dr. Taj?
Hello?
Dr. Taj, she's asking.
Propriospinal myoclonus, where there is a jerky abdominal movement. So the rest of the semiology again is not, or the phenomenology is not fitting into that also. There is no flexion or spreading from abdomen to the rest of the body part, like flexion of hip or knees. Nothing is coming in this case. Another situation where
those kids who present with Lance-Adams syndrome, post-hypoxic, we do get propriospinal myoclosis, which are, the phenomenology does resemble this, but they are kind of very stimulus sensitive. They tend to be very exaggerated, and with tactile stimulus, or sometimes even with auditory stimulus, there is a triggering of the propriospinal myoclonus. And they are very fast. They may not be rhythmic in nature, but they're very rapid and jerky, unlike what this child has demonstrated. And of course, they are definitely not distractible. And they're bilaterally symmetrical. They're symmetrical.
Thank you. Thank you so much. We did so much. We learned so much today. We go on to the last case. It's an adolescent. Dr. Diksha Gupta is the presenter, and the moderator is Dr. Pratik Panda from AIMS Rishikesh. Dr. Diksha?
My screen is visible and I'm audible?
Yes, yes, both.
Okay. So good evening all. I'm presenting a case of adolescent onset pseudo-refractory epilepsy from the Department of Pediatric Neurology. I'm Dr. Diksha Gupta, Senior Resident doing Team Pediatric Neurology, and this presentation is under the guidance of Dr. Pratik Kumar Panda. So we had a child, 14 years old female, Miss Z. She was a resident of Bijnor, UP. At present, she is under our follow-up in OPD. Her presenting complaints were multiple episodes of abnormal body movements for last 5 months. And she was referred to us from an outside hospital where a provisional diagnosis was kept to us, drug-resistant epilepsy. She had multiple paroxysmal events for last 5 months with complex motor movements of lips, face, and upper limbs. Also, she sometimes had eye closure, persistent gaze fixation, and it was often associated with post-ictal beeping. It was followed by complete recovery sometimes, or also prolonged periods of unconsciousness for hours together. All episodes were in the presence of caregivers. Further, she had no history of any clenching of teeth, uprolling of eyeballs, post-ictal confusion, or urinary incontinence, any accidental falls causing trauma, no tongue bite or nocturnal episodes. She was being treated outside by a private practitioner, and she was already on multiple anti-seizure medications from outside, but she had poor response to them. Also, she had multiple emergency admissions also. Here we have the videos for our patient. As we can see in this first video, she has complex motor movements, which is mostly voluntary movements. Followed by this, she has some out of phase complex flinging of the right hand, and she's trying to speak something, and there is vocalizations also which are not comprehensible. Coming to the next video, in the second video, we can see that she has this lip smacking like movement. She's trying to speak, but she has incomprehensible words which are not understandable by parents. She has some vocalizations and she's trying to speak, but those words were not comprehensible by the parents. These are some more videos of the same patient. As we can see in this video, this patient used to lie unconscious for hours together, up till 4 hours, and did not respond when parents were calling her, which increased the anxiety of the parents as well. Coming to the fourth video, we can see that she had this kind of persistent gaze fixation with continuous eye opening, having a staring look, but no motoric activity in this. But as we can see in this video, when the parents are trying to talk to the child, she's responding to them, and she's looking at the parents as well in between. Here also we can listen that the parents are trying to talk to her if she is having any stressor or not. In this video, we can also see that she has a cafe au lait MACU, and Here she had this rapid sighing breathing initially, followed by some moaning sounds, after which she wakes up and she has post-ictal weeping. As we can see now, she has this post-ictal weeping, which is quite characteristically seen in PNAs, which is post-ictally at the end of the seizure, moaning-like sounds, screaming-like sounds, which we can differentiate from ictal cry, which is more of a laryngeal sound and in the middle of the seizure. So with these videos, the first differential diagnosis we kept was psychogenic non-epileptic seizure, much more than an epileptic seizure, which could be temporal lobe epilepsy. And one could think of psychogenic syncope or paroxysmal dyskinesias, but which are very less likely. PNES is most likely, as she is a female, she has inconsistent semiology of the event, unusual motor phenomenon like out-of-phase limb phenomenon, side-to-side head movement, atypical vocalization like post-ictal weeping, and comprehensible word formation during the ictal phase. Also, she had eye closure characteristics like eye closure during the episode, persistent gaze fixation, and all of these episodes did not occur during sleep. It could be provoked by identifiable emotional stressor, and they were episodes of hyperventilation as well. Also, she could recall the memory of the event even if the episode seems to be generalized. And these episodes were refractory to multiple anti-seizure medications. One could think of temporal lobe semiology seizure because of automatism, staring, lip smacking, and repeated swallowing-like movements. But her being aware to the surroundings and responding to the parents' commands makes temporal lobe semiology seizure less likely. Here, I would just like to add 2 points that PNES accounts for 10 to 40% of drug refractory epilepsy coming to the tertiary care centers. And as per the Senevich-Ratne and colleagues classification, our patient seems to have mixed PNES more likely than complex motor PNES. So we did a psychometric evaluation, and on further interviewing and performing house tree person tests, multiple stresses were found. She had financial constraints in the family, conflicts amongst the parents, poor scholastic performance, and no peers to interact. Further, on her evaluation, her full-scale IQ was 92. There was no evidence of any learning disability. CBCL showed significantly elevated T-scores in the domains of withdrawn and anxious behavior and somatoform complaints. She also had moderate to severe anxiety and borderline clinical depression. Her investigations which were done outside, CT was normal, ECG was normal, and EEG was also normal, and MRI brain was also done outside, which was a normal study. We thought of the case being as PNES upfront, and we went ahead with a video EEG with suggestion, which provoked similar event without any ictal correlate in the video EEG. And her EEG was completely normal, just with a posterior dominant alpha rhythm. We further did cognitive behavioral therapy on multiple occasions. Anti-seizure medications were gradually tapered and stopped. Simultaneously, parents were also counseled to avoid conflicts in front of the child, and she eventually became event-free. Her somatoform symptoms also resolved and on the follow-up done after 3 and 6 months. So this was her final outcome, and the parents shared this video with us that the child is doing quite fine and she's completely normal.
हमारी पहले इसकी तबीयत खराब थी, दौरों की वजह से अब बिल्कुल ठीक है।
Thank you.
Thank you so much. Nice presentation. It's open to the experts. Please. No, I think Dr. Pratik is there. Did I see him? Dr. Pratik?
Thank you, ma'am. Ma'am, I just wanted to highlight one thing. Seeing multiple videos which looks like PNES does not mean that the child had also a history of two seizure. Sometimes seizure and PNES coexist. So in such cases, when we are tapering anti-seizure medications, we need to be very careful, because we have some cases when the true seizures actually increase after the tapering of anti-seizure medications. That is the one thing I wanted to highlight.
Yeah, you're right. Now we go to the experts. Ma'am?
I think a very clear case, and I think the video EG was also done. Everything was very nicely presented, and the way she told us about the duration of this thing and not respond, I mean the awareness, it was all the points which were distinguishing the true epileptic seizures and the non-epileptic events were pointed out during the discussion by the presenter. I think very well presented and very good videos. So nothing to add. The only thing again is it's tough one, and I'm glad that the patient had a very good outcome. Yeah.
That's right. Dr. Taj.
Very interesting case. So to me, any event that looks like automatism but lasts more than 10 to 20 minutes, first think of non-epileptic in nature. And one of the history probably that could have helped us is there any certain location or a certain event or a certain emotional trigger that may predispose this child to evoke such actions or behavior. So if there's a certain stereotypy or similarity in such triggering factors, then probably we could have made the diagnosis of PNS slightly more easier. Anything more than 10-20 minutes, automatism like most likely not seizures.
So the other thing I wanted to ask people, the experts, was this suggestion therapy and giving injection saline. There are lots of ethical concerns with that. I'm not sure what would be the normal way of bringing out this. Simple verbal suggestions and all are okay, but not doing extra nauseous stimulus or giving saline is not recommended. So you have to be careful while doing. We have to be also very ethical in our. So I hope none of these things are doing. Some people do, giving injections and all to get, that's that I would not recommend that, because very often I see that being done. I don't know what Dr. Taj and Mary and Dr. Shipali have to say about that.
Dr.
Dr. Taj, you
Shefali?
want to say? Yeah, no, we obviously not all these. We just do the verbal one,
Yeah,
and
but
actually, yeah, we don't do all that. The verbal and the tuning fork and compression, but
yeah,
not
that's it. Yeah.
anything, not
No
injections or anything.
invasive, yes.
Yeah.
We must say
Yeah.
that should not be
No, we
done.
have done. No, we had done as a MD thesis also. Priyanka Madan, who did DM also, before that, her MD thesis was on psychogenic non-epileptic events. So we had a long series and we could do, although we've been doing now regularly. So that is very clear. Verbal or, something like a tuning fork or something like that. Dr. Taj, your this thing. And one more thing is our protocol is final take-home messages from the expert and the moderator and anybody else. So one take-home message has to be given. First, you can reply to this question and then give a take-home message. Meanwhile, Asmita will once again show. Before you think about the take-home message, just one thing I wanted to say before people are logging off. One thing is that we are going to be having a quiz, and after that quiz, we would be we will the prize actually. I was just discussing with Dr. Maya. So we will selecting some people who win the quiz. Will be having a registration free for the next AOCN National Conference. So that we will decide and will come up soon. So that will be something important. And Sangeeta, in the end, after everybody's given the take-home message, talk about the conference again. Please, Dr. Taj. Yeah.
So the thing about being ethical or not ethical is in one side. So, in PNES, suggestibility is one of the strong clinical criteria for us to consider to make a diagnosis. So the question is always out there, how far can we go in our act of suggesting to a child? Where do you draw the line? So I've got consultants back in the US who didn't inject any saline, but they went as far as acting as though they injected something. So where do you draw the line? It is suggesting to the child that you might be giving something which might be working. So you are basically doing some form of behavioral therapy. So the neuropsychologist there does say, there's nothing actually wrong because you're not inflicting any form of injury to the child, but some would actually disagree with that. So the ethical argument here or debate, might be a little tricky and might not be that easy. But to me, play it by ears. Of course, giving some tablets or injecting anything might not be the right thing to do, but suggesting as though you're giving something, should be okay.
Yeah,
only if but only till suggestion. It's not the actual thing. So there's no point to suggest that, and I still feel it's not ethical to scare the child about it. You can have suggestions in other ways to go about doing. I think that would be important. Somebody's asking for YouTube links. Mail will be sent to all of the attendees because this is the 27th webinar of the series, and all the 27 webinars will be available. And Asmita, please note that there are too many patient videos, so they have to be blurred before we put it on the YouTube. So all the faces will have to be blurred. So you'll have to take some time. Please discuss with Mansi. This was there for Dr. Hassan's presentation also, and I think for all the videos will have to be blurred because I think nobody blurred or in their videos. So before it goes to YouTube, has to be blurred. And now take home message is Dr. Taj. Your take home message. Final take home message.
Everything that moves is not seizures, probably is take-home message. That's the best take-home message anybody can give, I think. But of course, always look at the phenomenology, and you probably will be able to have a more focused approach when you are clear with the phenomenology. So focus on the phenomenology.
Yeah, Dr. Aneja, ma'am, with your experience of the
So
whole
what
lifetime,
yeah, I would say we have seen some snippets of some of the things which shake and dance, but there are many others which have been left. For example, syncopal attacks, which can also be very tricky. Maybe like anoxic spells. So there are many which are common. Breath holding spells,
shuddering
ITS.
attacks.
I have seen ITS being treated as status, as well as tetanus being treated like that, and tetany. So, I mean, there's still a large amount, and maybe we might have, many others which have not been dealt with. But what Dr. Taj has said is very important. And I think the history and the home videos, these are very critical in making diagnosis, and taking a good history is the paramount importance.
I think actually the idea was, which I told Ranjit, was we should have the entire age spectrum so that you just get a flavor of it and just have a feel of it. Obviously, and you can invite cases should be invited in the across spectrum. It should not be of the similar kind. Dr. Sujata, you have been moderating, so your take-home message.
My take-home message is that, as we all know, the very first step to managing a child with seizures is to be sure that this is a seizure. So is this a seizure or not? So for that, we need to know, as Dr. Taj and Dr. Aneja both said, history taking most important, phenomenology very important, and we need to know that this truly is a seizure before we start treating. So we need to know all seizure mimics. I think sessions like this are very helpful because we see a wide variety of cases from all over the country and worked up very well. So thank you so much, Dr. Shefali and Dr. Ranjit, for putting this all together for us. And
thank you. Dr. Mahesh, final message. No, we have forgotten a secretary. Mahesh, final take-home message. Mahesh?
Yes, ma'am. It was like a real good collection of cases. Congrats to Ranjit for a very good comparison of all type of seizure mimics. And I fully agree with Dr. Taj, ma'am. Like, all that shakes is not a seizure. So we need to really look at the videos and analyze them properly. So we make the distinction. Message for pseudo seizures, we should not work it up more in detail because that will again make them do it more. So you should make it positive diagnosis of pseudo seizures. That was my message.
But Mahesh, one thing is that parental counseling is very important in this PNAS because the parents have to be convinced, because otherwise if you don't do, they will go to somebody else. I mean that becomes a tricky situation. I agree. Ranjit, you should give some message, right?
Yes, ma'am. I think like every time a case is referred to you with a diagnosis which has already been made, you don't just go by the diagnosis, a referral diagnosis. You try to make your diagnosis on own, and you get convinced with what you have made. And thank you very much to Dr. Sujata for entire series and for her being a moderator. Thanks to Dr. Satindra Aneja for her expert comments, and thanks to Dr. Tajul for accepting our invitation. I intentionally try to not to keep simple cases like benign sleep myoclonus, jitteriness, because we pediatricians have seen most of often. So we try to keep a spectrum of cases which are typically not covered in routine seizure mimic talk. Thank you very much. And we had a maximum.
Thank you, Ranjit. Yeah. Ranjit, and I would like to ask any of our panelists or anybody on the SIG members want to say anything? Any SIG member? Otherwise, Asmita, please share the screen for the conference, and Sangeeta, please. Sangeeta can talk about the conference, please.
Yes, ma'am. Thank you, Shefali ma'am and AOC and team for organizing this wonderful webinar session. It was a great learning experience for all of us. And with regard to the conference, as you all know, Child Neurocon 2024 is happening in CMC Vellore from 8th February to 10th February. We have 5 interesting set of pre-conference workshops and also have excellent scientific sessions in the main conference. So we'd like to extend a warm invite to all the pediatric neurologists, pediatricians, and pediatric neurology trainees across the country to attend the conference. The conference registration link is already open, and we are also inviting abstract submissions, which has been already open on the website. So kindly refer to the conference website for the registration links and start submitting the abstracts as early as possible. Thank you, ma'am.
Yeah, thank you. And as Ranjit and a team of people along with him will be having a quiz. We'll be putting up a quiz for you, and the winners will be getting a registration exempted for the conference. I have requested Dr. Maya to do that. So I think thank you so much. And I'm really grateful to all the presenters and their moderators, many of who have been my students, and really grateful to all the attendees. And obviously also grateful to, very importantly, to our guest, Dr. Tajul, and we actually, when we were discussing, myself and Ranjit were talking, and then we said, yes, all are movement disorders. So the best person has to be you. And Dr. Reja has a vast experience of a lifetime of seeing. So we thought that would be the best combination. Dr. Gagandeep couldn't join because he was in the ILE meeting, which got extended. So so I think we thought that the adult side would be there in case for some adolescent and all input would be there. And really grateful to Dr. Sujata for moderating, and Ranjit as usual. I mean, you're amazing. And thank you, everyone. I think we just, just keep your every Wednesday, 8 to 9:30 p.m., all IST, all ready, and all different SIGs coming up till January 2025. So thank you so much. And good night to those, but good evening and good morning to some, because I know there's across the board people are there. Thanks for joining.
Thank you so much, Dr. Shefali.
Thank you.
Bye.
Thank you.
Thank you, ma'am. Good night. Good night.
Good night.
Thank you.
Good night. Good night.
Good
Good night.
night.
Thanks. Thank you, Dr. Taj.
Bye.
Thank you. Thank you, ma'am.
Bye.
Thank you.
Bye.
Thanks.
Very nice hearing you,
Bye.
Dr.
Good night.
Yeah.